Thank you, Heather. So let's start with our agenda for today. My plan is for us to talk a little bit about this webinar series, and then we're going to spend some time exploring disability from a misfits perspective. We'll also talk about common modifications and communication aids and tools, and we'll end with some Q&A. So as Heather mentioned, this is part 3 of a four-part series of webinars on the ADA, or the Americans with Disabilities Act, and healthcare. And in addition to these 4 webinars, we're also making fact sheets and a series of short videos on topics relevant to healthcare practitioners. This is a collaboration between the Oregon Health Authority and the Northwest ADA Center. On this slide right now, we have information about our last webinar. It's going to be on disability allyship in healthcare on April 4th. There's also a link on the slide where you can register for that webinar and also learn more about the series. I'd like to share a little information about where we work, the Northwest ADA Center. So the Northwest ADA Center is part of a national network of ADA centers, and we're funded to provide information about the Americans with Disabilities Act to help people understand how this law applies to their lives. So on the slide is a map of the different regional ADA centers, and we're Region 10. We work in Idaho, Oregon, Washington, and Alaska. You can ask us questions about the ADA. It's free and confidential over the phone or email. We have a 1-800 number. It's 1-800-949-4232, where you can reach out and ask any questions about this law. I'd also like to spend a little time introducing myself. So I'm Katie Warden, the director of the Northwest ADA Center. I'm a lawyer and a sociologist, and I identify as a person with a disability or a disabled person. I have type 1 diabetes, ADHD, and an assortment of mental illnesses. And I share that with you all because I want you to know that this work is important to me both personally and professionally. And also that one of the things we're going to talk about today, reasonable modifications, this sort of flexibility and openness to changing our policies and practices, that's been key to ensuring access for people with impairments like mine to all kinds of spaces, including healthcare. And I want to note also that in disability activism, we're often encouraged to share our relationship with disability because that can affect, our views on disability rights, what issues seem important to us. It can also limit what I notice about the ADA or the things we're going to talk about today that might be apparent to someone who has a different disability or a different relationship to disability. Now on the screen is our disclaimer slide. So the Northwest ADA Center is federally funded. However, the information and opinions we share in our trainings are just that, our opinions, and don't necessarily reflect or represent the views of the federal government. And what we talk about today is not intended as specific legal advice. This is just helpful information. Okay, so today's learning objectives. At the end of the webinar, I'm hoping you'll be able to think about disability and accommodations from a misfit perspective, to think about how policies or practices in your healthcare setting might create a misfit or an exclusion for people with disabilities. I also want us to understand reasonable modifications as a way to create access. We want to be familiar with requirements related to service animals, as well as some best practices for providing effective communication. So it's sort of a combination of disability studies critique and some practical advice and guidance on how to implement the ADA. So let's jump into our content. Creating fit in an inaccessible world. So I want to frame the ADA requirements that we're going to talk about today as ways or tools to create fit for people with disabilities in a world that still is largely inaccessible. So remember, we're approaching disability from a diversity perspective or framework. And in our first webinar, Heather dove deep into different models or frameworks for understanding disability. Okay, there are many ways to think about disability, many ways to define disability. And we use this diversity perspective or framework. Right? We see disability or the experience of disability as about the interaction between one's way of functioning and the social and built environment in which someone finds themselves. In other words, individuals may have non-typical or even impaired functioning, right? We might be different, but it's societal barriers that disable individuals who have these differences. So another way to think about this, what we're saying when we say that people with disabilities have non-typical or even impaired functioning, we're recognizing the diversity of ways that people exist in the world, the diversity of ways that bodies and minds function, right? That some bodies might move walking on two legs, some bodies might move through space using mobility devices. Some body minds might communicate with speech. Some might communicate with behavior, written words, or communication devices. Some body minds might process information faster or slower. And it's a recognition of how diverse human beings are. So on this slide, we've got two arrows pointing towards each other. And one arrow has the words body-mind. And that's representing our embodiment, all of the ways that we move and think and communicate, and that sometimes are not typical for people with disabilities, a little bit different. And on the other arrow, we have the word social environment. And this is referring to all of our expectations, assumptions, policies, and practices, kind of the social norms we have about how to behave in public, how we typically do things. And disability in this perspective, it's what happens when kind of a non-typical body-mind, right, is in an environment or meets this social environment that doesn't fit or accept those different ways of being. And so the social environment, right, these are all of the expectations and assumptions that we make, often about uniformity. We assume that people move and think and communicate in the same ways. And these expectations influence our policies and practices, right? Maybe we assume all people can get into the dental chair independently. Or maybe we assume that all people can and do sit quietly in a waiting room. And these expectations, when they get built into policies, can exclude people with disabilities when we move or act or communicate differently in non-typical ways. There's a misfit there, right? There's a misfit between the way we exist in the world, the way we move and think, and policies and procedures, practices that assume everyone is the same. And so people with disabilities, we don't always fit expectations. We don't always fit into the standard policy or practice. And that means we can be excluded. We can be excluded and not get the healthcare we need and have a right to. And so as we're talking today, you might keep in mind, what are some policies, practices, the typical ways you do things in your healthcare setting that might exclude people with disabilities? Where in your practice might you be assuming that everybody acts and thinks and communicates in the same way? And so this perspective this understanding that seemingly neutral policies can be discriminatory for people with disabilities when these policies don't fit our needs and aren't flexible. And so that perspective is built into the Americans with Disabilities Act. And so I want to share with you some congressional findings that are noted in the ADA. And these findings are the reasons, according to Congress, why we need the ADA, why disabled people need civil rights protections. And so Congress found that individuals with disabilities continually encounter various forms of discrimination, including the discriminatory effects of failure to make modifications to practices. In other words, when we don't adjust the way we typically do business, the way we typically provide healthcare, when we aren't flexible, that can be discrimination. So let's get a bit more practical. On this slide are some common and seemingly neutral policies that are common in healthcare settings. And these are policies that can exclude people with disabilities. We see settlement agreements, court cases, guidance documents on these topics, and that's why we're highlighting these policies in particular. And these are examples of practices, policies where we might need to make modifications, we might need to make changes, be flexible in order to create access for people with disabilities. So that first policy is a no pets allowed policy. There's also policies that ban all non-patients in healthcare settings or limit an appointment to only the patient. They can't bring a support person with them. We also see policies around inflexible time limits for appointments. Right? Everyone has a 30-minute appointment or 15 minutes or an hour. It's a set time for everyone. We also see the practice of providing information in only one modality or only one form, right? We're only giving patient notes in a written PDF, or I'm only communicating with my patients orally, right? When we only have one form of sharing information. So what does the ADA require? It gives us clear guidance on how to be flexible, how to adapt our ways of doing business, of the typical practices we have to ensure access for people with disabilities. And so the ADA asks us to change the environment, right, including our social environment, to create fit for people with disabilities or to create access. And it gives us two great tools for doing this. We can change the environment by providing reasonable modifications and providing effective communication. Now, I keep talking about reasonable modifications, and that's the legal term to describe this type of accommodation in this setting, but it's absolutely fine to talk about these as accommodations. It's a much more common term. And your patients or clients, they might not even use the phrase accommodation. They might just say, I need something to be a little bit different to meet my needs, to fit me. There's no rule that we use any specific language to talk about these requirements in the ADA. I just want you to know that. Okay, and I want to emphasize, remind us all, we're doing this, we're providing accommodations or modifications. We're making sure our communication is effective, not because we're trying to be nice to disabled people or give them extra help, right? We're doing this because these are necessary steps to ensuring equal access. These are civil rights. And like I said before, I like to think of these requirements as tools that can help us meet the ADA's non-discrimination principle. These are tools to make sure your services are available in an accessible manner. They're tools to make sure that you're providing people with disabilities full and equal access to your healthcare services. Okay, so let's start by talking about reasonable modifications. What are reasonable modifications? Kind of been hinting at it, but I want to read the definition for you all. These are simply changes to policies, practices, and procedures when necessary to make healthcare services fully available to people with disabilities. It's important to note how broad and flexible this requirement is. There are common modifications, like modifying a no pets policy to allow service animals, but there isn't a list of every possible reasonable modification. And so this is a place to be creative, right? To be flexible and to be open. What changes can we make so healthcare is more accessible? On this slide, I have a link to a video from the University of Pennsylvania Dental School. And this school has an accessible dental suite where dental students learn to provide modifications. And in this video, there's a student who shows us one of the exam rooms. And she talks about possible modifications. And one of those modifications involves yoga mats. So they're in this kind of fancy dental room. There are yoga mats around where they can sit with a patient if someone's having an anxiety attack and wants to sit and breathe together. The dentists are being trained to provide those sorts of supports to help ensure that people with anxiety can access dental care services. And I wanted to just share this link and note that example because modifications can be anything. We can be really creative with them. We've got to think outside the box, and they don't always have to be expensive. It could just be having yoga mats available. Okay, but before we get too creative, let's review some common modifications. This is a big one. Of course, it's reasonable to have a no pets policy in your healthcare setting, right? We don't need parakeets flying around dental practices, but no pets policies, even in healthcare settings, must be modified to permit service animals to go wherever the public can go. And this includes places like inpatient rooms in a hospital, ambulances, exam rooms, hospital cafeterias, most spaces in a healthcare setting. There are limited exceptions, right? So service animals could be excluded from a burn unit or a surgical operating theater, right? A really sterile environment. They might be excluded there. And so I want to practice thinking about these modification or accommodation from that diversity or misfits perspective, right? We have this seemingly neutral policy. Of course, we don't want animals in a healthcare setting, but that seemingly neutral policy of excluding animals, it doesn't fit or work for people who use service animals. And so we have to adapt that neutral policy to allow for access. That's kind of the misfit perspective on this, right? When a policy misfits or doesn't meet the needs of someone with a disability, we've got to change it to create a fit so they can access the services. So it's important to remember that service animals aren't pets. There's a very specific definition of service animal in the ADA. Service animals are only dogs trained to perform a task directly related to someone's disability. These tasks can be wide-ranging. So a dog might alert someone to low blood sugar. It might remind someone to take medication. They could provide mobility support or alert someone to sounds in an environment. And they can also do tasks related to psychiatric disabilities, like licking someone's face to alert them to a possible panic attack. They can do specific tasks that help people recover from panic attacks too, like laying on top of or underneath someone. Service animals can be any breed or size of dog. Vests and certification aren't required, right? There's no registration process. There's no official uniform they're required to wear. And that's in part because the ADA explicitly allows disabled people to train their own service animals. And I'm happy to answer questions about service animals when we get to the Q&A. This is a big issue that we see in healthcare and many other settings. Okay, so our next example or common modification is about time. So policies about how long medical appointments should take can exclude people with disabilities. Seemingly neutral policies like scheduling all patients or clients for a 30-minute exam can be discriminatory. And so a common modification is simply to provide longer appointments. You can schedule time in for things like using plain language to explain medical diagnoses or treatment options. Schedule time in for a patient to process the information you're sharing. You might schedule time to help a patient undress or dress, get on or off the exam table. You might also need to schedule more time to provide effective communication, time to set up assistive technology, or to account for interpretation. As I want to read you all like a very strong quote from the Department of Justice on this requirement. You cannot refuse to treat a patient who has a disability just because the exam might take more of your or your staff's time. So then the DOJ says, some examinations take longer than others for all sorts of reasons in the normal course of a medical practice. Okay, and so on this slide, I have a link to an excellent resource from the CDC. It's their program about disability allyship, and we're going to talk more about the program and see some more of the resources in the next and last webinar in our series. But on this slide, I have a short video of someone explaining how important it is for providers to take the time to listen and to really explain healthcare information.
When I'm at a doctor's office, hospital, or clinic, I want to make sure that every doctor I see takes the time to talk to me about what's going on with my body, what kind of treatments do I need, what kind of medicine do I need, and just taking the time explaining what it's going to do, how is this going to help my health, and how I'm going to have a healthy future.
If you go to this website at the CDC, they have so many stories, little clips like this, where people are just emphasizing again and again the importance of taking the time to really explain what's going on in a healthcare appointment. Okay, so our next common policy is about support people, right? And so we have seemingly neutral policies where only the patient may attend an appointment. Or maybe there are policies that ban all non-patients in healthcare settings. Of course, we saw more of these kinds of bans or policies during COVID. And some people with disabilities need a support person to help with medical decision-making, to help them share their medical history, to help explain information in simple, understandable terms, right? They can ensure that the information the provider has is necessary for treatment. So we're talking about accommodations again, or changes that people need to access healthcare. These aren't just preferences or likes, right? So some people do need a support person to help them access and make decisions about their healthcare. And I want to note that even though people might bring a support person who helps explain aftercare instructions or share medical history, that doesn't meet our obligations to provide effective communication, right? We still have a separate obligation there. We can't rely on a support person to ensure communication is effective, but we should make an accommodation or modification to allow them to participate if that's what someone needs. Okay, So we're wrapping up reasonable modifications now. And I want to share 3 quick tips. We've got resources that get into the details of how to do these steps at the end of the presentation. But it's so important to make sure you have a policy in place for how people can request and receive accommodations. Just as important is ensuring that your staff is aware of the policy, knows how the process works. And then last, we always want to be thinking about these situations, accommodation or modification requests on a case-by-case basis, right? People with disabilities, even if we have the same diagnosis, the same medical condition, we are still individuals with unique and diverse needs. And so making any sort of blanket decision, this is what we're going to provide for all people with X disability, right? We can really get into trouble there because that might not ensure access for everyone because we are so diverse. Okay, before we move on to effective communication, it is important to know that there are some limitations on the reasonable modifications that we have to provide. So first, if an accommodation or modification would fundamentally alter or change the essential nature of your healthcare services, you wouldn't have to provide that. So one simple example of this might be where a patient requests a virtual appointment, but they actually need to see a provider in person because the appointment's going to involve kind of in-person checks, monitoring someone's body, looking at a tumor, touching a body, right? That can't be done over a remote appointment. And so that would fundamentally change the kind of service someone's going to get. On the slide, there's a link to guidance from the Health Resources and Services Administration. It's a federal agency on how to make these sorts of determinations. Is this a fundamental alteration? Would it really essentially change the nature of our healthcare services? It's a good resource. Another limitation is called direct threat. So if an accommodation would pose a threat to the safety of the patient or others, you don't have to provide the accommodation. This is a high level of of safety. It has to be a serious threat, can't be based on stereotypes. But there is this exception. And this is why service animals can be excluded from a surgical operating room, right? They could pose a direct threat in an environment that's very, very sterile, like an operating theater. I want you to know that these limitations are rare. They really are rare. And you might notice also that cost isn't a limitation or a reason not to provide an accommodation listed. Administrative inconvenience or hassle, it's also not a reason not to provide an accommodation. Okay, so moving on to effective communication. This is a critical requirement in an area where we see so much legal activity, especially in healthcare settings. And why is that the case? Because miscommunication in a healthcare setting can lead to misdiagnosis, improper or delayed medical treatment. Right? This is a crucial requirement in healthcare settings. Without effective communication, a healthcare provider might not know what services to provide, might not clearly explain the procedures that are going to happen, and they might not get the information from a patient that they need to make a diagnosis or a decision. So what does effective communication mean? What does the ADA require? It's actually a simple requirement. The law is requiring, it's asking us to ensure that communications with people with disabilities must be as effective as communications with others. Right? So think about any information that you share, any questions you ask, orders you give, paperwork you have patients fill out, instructions you provide. Can people with disabilities understand that information? Do they know what you're asking? Do they have a way of answering you and sharing information with you? So even though this is a simple requirement, it's important to note it applies throughout all points of your healthcare practice. Any interactions where patients and providers might be sharing information. So on the screen, there's a graphic of different points of contact, moments when communication might be exchanged between a patient and a provider. This graphic is it's from guidance from the Centers for Medicare and Medicaid Services. And there's a link to this guidance document at the end of the presentation. It's really helpful guidance on looking for barriers and ensuring access in our policies. So at the top of the graphic, there's a circle of different points where patients are going to need to give or receive information. And we're going to start with appointment scheduling. So this is so critical. People encounter so many barriers at this stage, trying to schedule an appointment and being told, oh no, you need to provide an ASL interpreter. Oh no, you need to bring someone who can read the paperwork for you. This is such an important moment because it can it shapes the rest of the healthcare experience. So what if you had a policy in place and all staff are trained on it and aware of it? That is part of your scheduling process to ask what kind of communication aids or modifications or assistance might you need. So then in the graphic, we're next going to think about the information someone might need as they first enter your facility. Is there a security or information desk? Is there information someone might need to find your office once they're in the building? What communication happens when a patient goes to the reception desk? What kind of paperwork do you collect? How do you communicate with patients in the exam room or therapy session? And what about communication or information that's shared as aftercare, like prescriptions someone might need at the pharmacy? So communication, right? The sharing and receiving of information, this must be effective. Right? People must understand what you're trying to say and communicate at all of these points in the healthcare experience. So how do we make communication effective? What do we do? And the law asks us to provide what are called auxiliary aids and services, or communication aids and tools that are needed to ensure kind of effective communication. Right? These are simply tools that allow communication to happen. And so they include things like American Sign Language interpreters, video remote interpreting, note takers, large print materials or Braille, captioning, accessible electronic and information technology. It includes more than that. Those are just some key types of communication aids and services that you might provide in your practice. And at the bottom of the slide, I note that interpreters must be qualified. This is a really important point. This isn't the same thing as being certified. So the law is requiring that an interpreter is qualified if they interpret effectively, accurately, impartially, and if they're using any necessary specialized vocabulary, right? So in the medical or healthcare setting, are they aware of medical terminology? Are they going to be able to explain the details of the operating procedure, right? In some ways, being qualified is actually a higher standard than being certified. So I want us to think back again and remind us about this diversity or misfit type of perspective on disability. That people with disabilities, we might be excluded when the social environment, our typical way of doing things, including our typical ways of communicating and sharing information, when that doesn't fit the way that we communicate, we can be excluded. We can misfit in a setting. And so when we provide communication aids and tools like these, when we're flexible in how we communicate, we create access or fit, right? We're challenging our typical standard, seemingly neutral, but often discriminatory habits of assuming that all people communicate in the same way. So how do you know what tool or aid to use, right? It's not a one size fits all. Again, over and over, this is case by case. Think about the individual. So here we start with the person with the communication disability. What is the person's usual method of communication? What communication aid does the person want to use? Remember, people with disabilities are diverse. So some people who are deaf use ASL. Some people who are deaf use assistive listening devices. Some people prefer captioning. Not all deaf people are fluent in English. They might be fluent in ASL instead. So don't make assumptions. Start with the person and ask how they communicate. Then we think about, is this a complicated or a simple type of communication? Are we trying to reschedule an appointment or ask a simple question about billing? Right? Maybe writing some notes might be effective communication in a simple exchange like that. Or are we communicating information that could affect someone's health or treatment? Would writing notes really allow for meaningful communication if you're asking someone to give you details about their medical history, right? Could that really get into all of the details and stories that you would need as a provider to understand what's really going on with someone? So I want to note there's a difference here in the law for healthcare providers that are a part of state and local government agencies. So the ADA requires state or public providers to give primary consideration to the person with a disability's choice of communication aid. So if someone says, I want ASL interpretation in my appointment, you must honor that choice, that request, unless you can demonstrate that there's another equally effective means of communication available. But if this is the person's choice, this is the communication they use, it's unlikely that there will be an effective means of communication that's equal. Now, private providers, people in private practice, you're just encouraged to honor the person's choice, not required. But I want to share some practical advice with you all on this point. I was talking with an attorney at the Department of Justice about this issue, about kind of the need to give primary consideration to someone's choice and how that differs between public and private providers. And he said, remember, as soon as the communication that is provided is ineffective, right? As soon as you ineffectively communicate, you violated the law and you can't take that back. So he recommended that even providers in private practice, even though they don't have that same level of legal requirement, that in order to ensure effective communication, it's a best practice to still give primary consideration to the person's choice. And I thought that was very practical advice from him. And so kind of, as we've emphasized over and over, this is case by case, contextual, based on the individual with the disability. But there are situations where interpreters are likely required when the communication is complicated, complex, or lengthy. And so I'm about to kind of read through some bullet points on this slide. There's going to be a lot of text, a lot of bullet points, and I'm doing that intentionally because I want to emphasize how often, in how many scenarios, interpreters are probably required. And these bullet points come directly from guidance from the Department of Justice, and it's linked at the end of the presentation. Okay, so interpreters are likely required when discussing a patient's symptoms and medical condition, medications, medical history, explaining and describing medical tests, treatment options, medications, or surgery, providing a diagnosis, prognosis, recommendation for treatment, obtaining informed consent for treatment, providing instructions for medications, post-treatment activities, and follow-up care, providing mental health services, including group or individual therapy, providing information about blood or organ donations, explaining living wills and powers of attorney, discussing complex billing or insurance matters, making educational presentations like birthing and new parent classes. So if you're encountering any of those scenarios, more likely than not, if someone's preferred method of communication is ASL, an interpreter is going to be necessary. Now, this is an interesting part of the law. This requirement to provide effective communication, it doesn't just go towards your patients. It also goes towards companions. And so this includes kind of parents, right? So if someone's parent needs a communication aid to participate in their child's appointment, that aid needs to be provided. If someone's admitted to the ER and the companion who brought them to the ER needs a communication aid, that must be provided. And so who companions are is a pretty broad category under the law. It includes any family member, friend, or associate of a person seeking or receiving healthcare in this case, who's an appropriate person with whom the entity should communicate, right? Like a parent, like someone who's brought someone to an appointment or to the ER, someone who's involved in the healthcare issue. We do see kind of settlement agreements, issues around birth or labor, right? And ensuring that everyone involved in that process, partners, are also provided with interpretation if that's needed, not just the patient. Okay, and then this is a key thing to note. You can't charge people for providing a communication aid or for providing a reasonable modification, right? So healthcare providers aren't allowed to place a surcharge or an extra cost on an individual with a disability to cover the costs of the aids or services or modifications. So you can't charge someone more if you're doing a longer appointment with them, if that's a needed accommodation. You can't require a patient to pay for an interpreter. Okay, so we have two key limitations to the effective communication requirement. First, you don't have to provide a communication tool or aid if it would result in an undue burden. Now that's a significant difficulty or expense. And this can change kind of based on the size of your practice, how well your business is doing that year. And in private practice, right, this is thinking about all of your resources, all of your overall expenses. If you're associated with a larger healthcare provider or organization, right, their resources can also play into the equation of, you know, is providing interpretation for an appointment really an undue burden for a large hospital? No, right? That's unlikely that that would ever come up. because we're thinking about all of the resources an entity has, kind of not just thinking about profit related to a particular appointment. The other limitation is fundamental alteration. And this is really rare in the effective communication part of the law, right? Would providing interpretation change the nature of a healthcare appointment? No, not really. Would providing audio recordings of written materials or providing materials in Braille change the nature of your healthcare services? No. And so these limitations exist, but they're rare. Okay, so let's talk about what to do next. I just got some really great resources that I want you to be aware of, and we've got links to them in these materials. Okay. So first, we want to evaluate for policy and practice barriers. In the last webinar, we talked about using checklists to evaluate for physical barriers, and we can do something very similar with policies and procedures. And so the first link on this slide is from CMS, the Centers for Medicare and Medicaid Services. And it's a tool that you can use to evaluate your practices and procedures. So I've got an example question from the tool on the slide. Do patient intake forms include an area to capture patient needs related to accessibility? Really great tool. The second link, also from CMS, is actually a guide for people with disabilities. And it has example questions that disabled people might want to ask before their appointment, during scheduling, during the appointment. And I think these questions could really help healthcare providers identify where people might encounter barriers. Kind of what's the experience like for someone attending your practice. So some questions from this guidance are, can I schedule extra time for my appointment? What's the best way for me to record what I discuss with my provider? Will a visit summary be provided in an accessible format? Or could I use a recording device during the appointment? Some helpful tools, I think. Okay. Now, on this slide, we've got links to model forms and policies. So you don't have to rewrite, from scratch a policy. They already exist out there. So there's also a screenshot of a model communication assessment form. This is from a settlement agreement from the Department of Justice. And it's a really simple form, right? Just it says, we ask this information so that we can communicate with patients or companions who are deaf or hard of hearing effectively. All communication aids and services are provided free of charge. If you need further assistance, please ask your nurse or hospital personnel. And then they've got like blanks to fill in the nature of the disability, relationship to the patient. And there are similar forms for accommodations as well. Okay, I just have to tell you all about ADA.gov. The Americans with Disabilities Act website is excellent. Really plain language explanations of this law would be great for patients or providers. And I've got links to key ones related to healthcare on this slide. Our last resource is again the Centers for Medicare and Medicaid Services, their project about creating more accessible healthcare. There's a link to a free training course. It's really good. A resource list they have, and then a link to the main homepage for this project. And now we have a little bit of time for Q&A. And if we don't get to all the questions, I know we can follow up over email as part of kind of the work we do typically at the Northwest ADA Center too. So can I pass it over to you, Heather?
Yeah, this is Heather speaking. Thank you, Katie. We have a fair number of questions that have come in. I've been trying to answer some online, some privately, and some publicly, but I'm going to try to combine a few of these questions that have similar themes. And so the first question that came in is from Heidi, who's asking, do you have any have you heard any specific information or federal guidelines regarding some circumstances in which a state or local government agency provides information only in an electronic format, i.e. will only provide it through email?
As opposed to kind of sending a paper copy or
Yeah, and
or documents in Braille or an audio recording.
I think I misread this. So
Yeah.
it's regarding documents that do not allow a state or government providing information electronically.
No, I haven't heard of that. From first glance, that feels right. The requirement to provide documents in only one form or format, right? In general, a blanket policy like that doesn't allow for providing, intake forms or aftercare visits in multiple formats. Typically, that would be a violation of the law.
Thank you.
Yeah.
And then we've got a couple of questions regarding attention around HIPAA and protected medical records. And so, for example, one participant notes that they've had folks been denied information through their coordinated care organization due to HIPAA verification processes or protocol questions, release of information concerns, etc. So what do you recommend? What is the most direct way to communicate the need for a modification to support communication by having somebody else have access to this information? What's the most direct way to communicate that this is an accommodation need for a modification of allowing someone else to participate in that communication exchange?
Great question. I don't have practical advice there, except to say we have lots of guidance from the DOJ about the importance of allowing support people or an extra person, multiple support people, not just one, or thinking about interpreters, right? That, they must be kind of allowed also in the process, that HIPAA wouldn't prevent them. It wouldn't be an excuse to deny allowing an interpreter in the office. But actually, Heather, if this is I'd love to follow up with this question though, see if we can find something more specific.
Great. And so I'm going to ask that person if they're willing, they can send me directly a chat with an email address. We'll follow up. Sam Hawkins had a similar question. Sam, if you feel comfortable sending me an email address, we'll follow up with you. And just to note, I would add that probably being very direct and intentional in saying this is a disability accommodation need, so that you signal very clearly that you're asking for a reasonable modification, that you're not asking just to invite or violate HIPAA. A couple of other questions that have come up are regarding hybrid or remote access in addition to in-person access. And I'm going to summarize a couple of these questions with saying, are, for example, hybrid meetings? No one asked specifically about appointments, doctor's appointments. You addressed that already, but are hybrid meetings, that is an in-person meeting with remote access as an option, is that a reasonable modification?
Again, it's the sort of outside of the service animal context, we don't have these this is always a reasonable modification. This is always a reasonable accommodation, no matter the context. But in general, you think through it using that framework. Would providing remote access fundamentally alter the nature of this meeting? Right. And we have kind of over the course of the last few years kind of found that more and more people, right, are getting remote work as an accommodation. Students are getting remote classwork as a reasonable modification, right? That we've learned that this is typically not going to fundamentally alter the nature of the meeting. But depending on the content of the meeting, I could imagine, right? I don't know, is this a group of massage therapists all practicing in person, different physical techniques? There might be scenarios where people do need to be in person, but in general, thinking through, would allowing remote participation change the fundamental nature of the meeting? Can people still share information? Can people still communicate, brainstorm? Likely going to be reasonable, but it always depends on the context.
Great. Thank you for that clarification, and just the awareness against the context is so important. We only have a couple of minutes left. There were a number of questions that we did not get to, and so I think we will try to follow up. I appreciate people sending me their email addresses, and again, we want to plug the last of our webinars in this series talking about disability allyship in healthcare. To those of you who have attended our last 4 webinars, I'll point out the language here is that we've tried to provide a lot of information about complying with the ADA, how to be flexible, how to be accommodating. And so when we talk about allyship, we're talking about going beyond simply kind of following the letter of the law and talking about common ways that disability bias can also create barriers and exclusion to access to healthcare, and some of the best practices for breaking down those barriers. And we're going to hear from both healthcare providers and patients and their perspectives on that webinar.
Well, thank you, Heather. Do you want to finish this off?
I think that's great. Thank you so much. Also, we have put a link in for evaluating this particular webinar. And note that if you are applying for continuing education credits, you will need to complete that evaluation as part of the form. So thank you all so much for raising really important questions. And thank you so much, Dr. Ward and Katie, for sharing this information.
Thank you all.